Somewhere in this country, right now, a family is sitting in a doctor's office hearing the word dementia. It happens to someone new every 66 seconds. And in a striking number of those cases, the real cause was never sitting in their genes. It was sitting in their medicine cabinet, in a bottle they trusted because a doctor's name was printed on the label. I'm not here to scare you. I'm here to hand you something almost nobody hands seniors. A plain, honest list. Because the truth is, memory loss doesn't always mean your brain is failing you. Sometimes it means a medication is quietly working against it, and no one has ever told you which ones. I'm Dr. Joseph Collins, and for years I've watched patients and their families mistake a drug side effect for old age. I want to be clear before we go any further. I'm not asking you to stop anything today. I'm asking you to listen, then take what you learn to your own doctor, because that conversation is where real change happens. Today, I'm walking you through 9 medications most closely linked to memory decline in people over 60, and then I'll show you the one hidden pattern behind almost all of them, something even most doctors don't screen for. Stay through to the end because that final piece is the part that changes everything. If you're watching this for yourself, or because you're managing a parent's medications, this is for you too. Before we begin, tell me in the comments how many prescriptions are sitting in your cabinet right now. I read every single one, and it shapes what I cover in this series. Let's start with number 9. Number 9, diphenhydramine, the little pink pill in almost every home. You know it as Benadryl. People reach for it for allergies, for a cold, or just to fall asleep faster. It's cheap, it's on the open shelf, and because you don't need a prescription for it, most people assume it's harmless. Here's what it's actually doing. Diphenhydramine blocks a brain chemical called acetylcholine, the messenger your brain uses to build new memories. A younger brain can absorb that hit and barely notice. An older brain, which is already making less acetylcholine every year, feels it directly in the hippocampus, the part responsible for laying down new memories. Research tracking regular anticholinergic use in older adults found the risk of developing dementia climbed by more than half compared to people who avoided these drugs. That's not a small shift, and most people taking it nightly never connect the fog they feel to the pill by their bed. Here's your move. Check anything labeled PM, nighttime, or allergy relief. Most of it is diphenhydramine wearing a different name. Ask your doctor about loratadine instead, which doesn't cross into the brain the same way. Never stop a medication on your own. Just start the conversation. Number 8. The acid reducers your stomach loves and your brain quietly pays for. Omeprazole and esomeprazole, sold as Prilosec and Nexium, are handed out for heartburn and reflux, and people often stay on them for years because the burning comes right back the moment they stop. Here's the part rarely explained at the pharmacy counter. Your stomach needs acid to properly absorb vitamin B12, a nutrient your nerves and brain depend on. Shut that acid down long enough, and B12 quietly drops, along with magnesium and calcium, minerals your neurons need to fire cleanly. The result can look exactly like early memory loss, when the actual cause is a nutrient your medication has been blocking the whole time. A large study following older adults on these medications found their dementia risk was over 40% higher than non-users. And separately, these drugs have been linked to higher levels of a protein called amyloid beta, the same protein tied to Alzheimer's. If you take one of these daily, ask your doctor about tapering onto a gentler option like famotidine, or whether you even still need it at the same dose. The goal is always the lowest dose for the shortest time, not a lifetime habit. Number 7. The bladder medication that reaches further than your bladder. Oxybutynin, sold as Ditropan, is prescribed for urgency and overactive bladder, a real disruptive problem, and the relief it offers is real too. But oxybutynin blocks that same memory chemical, acetylcholine, and it crosses into the brain especially easily. Research following adults over 65 on strong anticholinergic drugs like this one for more than a year found their dementia risk was nearly 50% higher. And here's what troubles me most about this one. Almost none of these patients were ever warned. They were told it would calm their bladder. Nobody mentioned it might be dimming their thinking at the same time. If this is you, and you've noticed yourself misplacing things or losing your train of thought more than usual, don't wave it off as age. Ask your doctor directly, is there a bladder medication that doesn't block acetylcholine? Newer options like mirabegron work through a completely different pathway and don't carry the same risk. 3 down, 6 to go, and the further we go, the more familiar these medications are going to sound. Some of them may already be in your hands tonight. Tell me in the comments which of these 3 you recognize, and stay with me for part 2, where we get into a medication taken by nearly half of all adults over 60. Before we continue, quick pause. If part 1 connected some dots for you, tap that like button right now. It genuinely helps this reach more families who need to hear it. And while you're there, tell me your age and how long you've been on any of your current prescriptions. I read every comment, and it tells me exactly what to cover next in this series. Let's continue with number 6. Number 6. The cholesterol medication nearly half of you are taking right now. Statins, atorvastatin, sold as Lipitor, and simvastatin, sold as Zocor, are among the most prescribed drugs on Earth. They lower cholesterol, they protect your heart, and for many people, they genuinely extend life. I want to say that clearly before anything else, because statins are not the villain. Diphenhydramine or oxybutynin are. This one is more nuanced, and nuance matters. Here's the piece worth knowing. Your brain is actually one of the most cholesterol-rich organs in your body. It uses cholesterol to build and maintain the connections between neurons. Statins cross into the brain and lower that supply. For most people, the body adjusts and nothing happens. But a meaningful subset of older adults report sudden memory fog, confusion, or word-finding trouble within weeks of starting or increasing a statin dose, and it often reverses once the dose is adjusted. The FDA itself added a warning about memory and confusion side effects to statin labels after thousands of these reports came in. That's not fringe science. That's the regulator agreeing something real is happening in a subset of patients. Here's your move, and I want to be precise about this one. Never stop a statin on your own. The heart risk of stopping abruptly can outweigh the memory concern. Instead, ask your doctor this exact question. Since starting this statin, have I mentioned any new memory or focus changes? Could my dose or the specific statin be adjusted? That single sentence, on record, is often enough to get a doctor to actually investigate rather than assume it's simply age. Number 5. The anxiety and sleep medication with one of the strongest links on this entire list. Benzodiazepines, lorazepam, sold as Ativan, and diazepam, sold as Valium, are prescribed for anxiety, sleep, and muscle tension. They work fast, they work reliably, and that's exactly why so many people end up on them for years instead of the few weeks they were designed for. These medications slow down the entire central nervous system, including the circuits your brain uses to form and retrieve memories. A large study following adults over 65 for 6 years found that those who had used benzodiazepines for more than 3 months had a risk of dementia roughly 50% higher than those who never used them. And the longer the use, the higher the risk climbed. What makes this one especially hard is that stopping suddenly can be dangerous. Seizures, severe rebound anxiety, and worse. This is never a medication to stop cold on your own, but it is one worth raising directly with your doctor. Is there a safe, gradual taper plan for me? And is there a non-benzodiazepine option we could try instead? A slow, supervised taper over weeks or months is standard, safe practice. And for many patients, mental clarity noticeably returns once the taper is complete. Number 4. The older antidepressants still being prescribed for sleep and nerve pain. Amitriptyline, often sold as Elavil, was developed decades ago for depression, but doctors still prescribe small doses today for sleep, migraines, and nerve pain, often without mentioning it's the same drug class at all. Amitriptyline carries one of the heaviest anticholinergic loads of any commonly prescribed medication, heavier than diphenhydramine, heavier than oxybutynin. Research on cumulative anticholinergic exposure found that adults taking a strong anticholinergic like this one daily for 3 years or more had a dementia risk over 50% higher than non-users. And unlike some drugs on this list, the added risk didn't fully reverse even years after stopping. If you're taking this for sleep or nerve pain, ask your doctor plainly. Is amitriptyline the right long-term choice, or is there a newer option with a lighter effect on memory? For nerve pain, alternatives like gabapentin work through a completely different pathway. For sleep, there are options that don't carry this same weight. That's 6 down, 3 remain, and I want to prepare you honestly, because number 1 on this list isn't a drug at all. It's something almost no doctor screens for, and once you understand it, you'll see why some of the people you love have been declining faster than their diagnosis alone can explain. Tell me in the comments, has a doctor ever reviewed every single medication you take, all at once, in one sitting? For most people, the honest answer is no. Welcome back for the final part. We've covered 6 medications so far: an allergy pill, an acid reducer, a bladder drug, a statin, a benzodiazepine, and an older antidepressant. Now we finish the list, and then I'll show you the pattern sitting underneath all of it, the one thing that ties every single case together. Number 3, the antidepressant that quietly ranks among the strongest anticholinergics prescribed today. Paroxetine, sold as Paxil, treats depression and anxiety, and for many people it works well. But among modern antidepressants, paroxetine carries an unusually heavy anticholinergic load, closer to an older generation drug than to the newer antidepressants doctors typically favor now. A study following adults over 65 found that paroxetine use was associated with measurably faster decline on standard memory testing compared with other antidepressants in the same class. The concerning part is how easily this gets missed. A patient feeling foggy on paroxetine is far more likely to be told, "That's your depression, not your medication," when both may be true at once. If this is you, ask your doctor this exact question. Is paroxetine still the best fit, or would sertraline or escitalopram treat the same condition with less effect on memory? Never adjust an antidepressant alone, but that one sentence said out loud in an appointment changes the entire conversation. Number 2, the antipsychotic prescribed off-label for agitation and sleep. Quetiapine, sold as Seroquel, is approved for conditions like schizophrenia and bipolar disorder, but a large share of prescriptions in people over 65 are actually written off-label for agitation, restlessness, or sleep. It calms quickly, which is exactly why it gets reached for. This is where I need to be direct with you. Regulatory agencies have issued a black box warning, their strongest possible warning, for antipsychotic use in older adults with dementia-related symptoms, linking it to increased risk of stroke and death, separate from its cognitive effects. And on top of that warning, quetiapine still carries meaningful anticholinergic load, adding to the memory risk we've discussed all series. If a parent or spouse has been placed on this for agitation or sleep, this is worth raising urgently. Was this prescribed for an FDA-approved use? And has a non-drug approach been tried first? Often, agitation has an underlying cause: pain, infection, poor sleep, even the anticholinergic burden from other drugs on this list that hasn't been investigated yet. That brings us to number 1. And number 1 isn't a drug at all. Number 1, nobody added up the total. Here's what I've watched happen over and over in exam rooms. A patient isn't on just one medication from this list. They're on 3, sometimes 5, each one prescribed separately by a different doctor for a different problem at a different visit. Each doctor sees only their own prescription. No one adds up the combined weight all those drugs are placing on the same acetylcholine system at once. This is called cumulative anticholinergic burden, and it's measured on a simple scale. The higher the score, the higher the risk. Research following tens of thousands of older adults found that once that combined burden crossed a certain threshold, dementia risk didn't just add up, it compounded, rising well beyond what any single drug on this list would predict alone. One large study put that combined risk at over 50% higher for patients carrying the heaviest cumulative loads. This is the piece your file is missing, because it was never any single doctor's job to notice it. It was everyone's job together, which in practice means it was no one's. Here's exactly what to do with everything you've learned across this series. Write down every medication you take, prescription and over-the-counter, on one page. Bring that single page to your next appointment and ask this exact question. Can we calculate my total anticholinergic burden, and is there anything on this list we could safely reduce or replace? That one page and that one sentence can do more than anything else in this video. I want to leave you with this. Nothing you've heard today means you did something wrong. You trusted the people prescribing these medications, and most of the time, that trust was reasonable. No single doctor could see the whole picture, because the system was never built to show it to them. But you can see the whole picture now, and your brain is more resilient than you've been led to believe. Given the right chance, clarity often returns. If this series helped you or someone you love, tell me in the comments which number surprised you most. And if you're managing a parent's medications, tell me that too, because it changes what I cover next. Subscribe if you want the rest of this work, because next, we're going through the everyday habits quietly aging the brain faster than genetics ever could. I'm Dr. Joseph Collins. Take that one page to your next appointment. It matters more than you know.